All right, we're live. So this afternoon's discussion is the 12 monkeys. So pick a scene, pick a character. Where would you like to start?
I guess we can start with the mental hospital in the beginning, and then the introduction of Jeffrey Goins, I believe his name is, Brad Pitt's character.
Okay.
And he seems to be very manic in the initial scene when we first meet him, and then obviously throughout the movie as well.
So let's kind of repeat what we did last hour in formulating the most likely diagnosis for Goins. And listen to the way I'm going to state the question, because I'm choosing my words very carefully. If we had 99 Rutgers undergraduates watch the 12 Monkeys, and you asked them, is Goins afflicted with a mood/anxiety disorder or a psychotic dissociative spectrum? What would the majority of those 99 undergraduates tell us? Psychotic, right? Psychotic dissociative. Good. And I'm glad we chose choice B again. Similar choice compared to the last hour, because it again is going to reinforce and emphasize that it doesn't matter which you choose, A or B. You're just choosing the path to take to get to the most likely diagnosis. We're going to get there either direction we go in at this point. If psychotic dissociative, what single illness should we choose to work from? Schizophrenia, yeah. What are the 5 inclusion criteria for schizophrenia?
I think apathy.
Apathy and other negative symptoms?
Delusions, hallucinations.
Hallucinations?
Disorganization.
Of?
Thought and behavior.
Perfect. Of those 5, we need 2. Is there evidence of 2 symptoms of schizophrenia in the character of Goins? There is. Can you be more specific? Delusions. The world may or may not end. By the way, if you want to watch this with Donnie Darko, there's a link there, but I won't go there. Anything else?
Disorganized.
Sorry, Lana?
Disorganized thought.
Disorganized thought process. Sure, he rules in. Okay. At this point, we appreciate that while ruling in for schizophrenia, this condition is a diagnosis of exclusion. What are the 5 illnesses that the APA says we must now investigate and rule out in order to continue to rule in and evaluate for schizophrenia? Autism spectrum, good.
Mood disorder.
Primary mood disorder, good.
Substance use.
Sorry?
Substance.
A substance-induced psychotic disorder, good.
Medical cause.
Due to an underlying medical condition and?
Schizoaffective.
And schizoaffective. You guys are on board with this. It's perfect. Of those 5, is there any one you would like to strongly consider here? A substance-induced psychotic disorder. Again, we can approach this in 2 ways. One, is there any discrete evidence in this script that Goins' character is using a substance that could explain his psychotic features? I'm taking the radio silence as no. Do you suspect a substance nonetheless?
I think you should. It's possible.
So, anything that hints at this where you can, again, take some creative liberty and say, Not to put words in your mouth, if I'm reading, probably not, but I'd like to keep it in my differential anyway, just because of my being that conservative type of physician. Sure, why not? Until that your drug screen comes back, until people close to Goins, family, friends, support system tells us, nah, no evidence here. We'll keep it in our differential. Good. And we can do the same for medical condition, right? And the other illnesses on that list of 5 you think should be a focus of our clinical attention?
possibly a medical cause?
Yeah, we're going to keep that in a differential. Primarily, not because there's evidence of it in the script, but because of our practicing in a conservative way and just wanting to rule out any organic pathology before we attribute the observed behavior to a mental disorder. And that's perfectly fine to state. Yep. Any other conditions in that list of rule-outs that we should discuss?
I guess mood disorders.
Yeah, let's talk about a primary mood disorder. First question is there any evidence that Goins appears to be depressed? Is there dysphoria, anhedonia, or any SIGI caps that you've observed? Is there any dig fast? There absolutely is. Right? And because of that, is it okay to include both mania as well as bipolar 1 in our differential? If the answer is yes, do you think it's higher in a differential than schizophrenia is?
That was my initial impression, honestly.
So the answer is yes. So I don't disagree. Especially because the American Psychiatric Association states that we have to consider mood disorder before we actually consider schizophrenia. It makes sense to keep that very high in our differential. So again, to reemphasize, if we think that the Goins character manifests bipolar 1, we could have gotten there by saying mood anxiety. But we're still there despite maybe choosing choice B, perhaps choosing the less direct route. We still end up there. Again, this type of practice, this way to formulate your ideas is a best practice. I would apply this to every patient you see, not only in your psychiatry clerkship, but any person that presents to you with signs of mental illness in your future practice, whether it be primary care, whether it be family medicine, whether it be emergency medicine, etc. So Goins' character appears to be afflicted with bipolar 1. What differentiates bipolar 1 from bipolar 2? Mania versus what?
Hypomania.
Hypomania. Good. So we're using big words now. What differentiates mania from hypomania? You knew that had to be the follow-up question,
Level
right?
of dysfunction.
Level of dysfunction, where if in mania we have evidence of clinically significant distress or impairment, that is absent in hypomania. And when hypomania alternates with episodes of major depressive disorder, then we have this clinical term called bipolar 2. What if mania doesn't alternate with any episodes of major depression? What do we call that? Bipolar 1, exactly right. Anybody know what percentage of time individuals will have experienced only a single manic episode in their bipolar 1 illness?
Not very high.
It's not very high. It's about 10 to 20%. Yeah. But that doesn't matter, right? What if there were episodes of established mania when Goins was 14, when he was again 18, that when experienced alternated with streptococcal infection?
Pandas.
Potential pandas. Always underlying medical condition. But let's say that's always ruled out, just for the sake of this academic exercise.
Illness induced?
Yes. Illness induced. Or, again, let's say that's always investigated and ruled out. Then what?
Medication?
Organic cause always ruled out. Again, just for the sake of this academic exercise. I'm not trying to trick you.
So mania that always precedes?
Or per the patient's report, alternates with episodes of streptococcal infection. That's bipolar 1. Right? Mania that alternates with episodes of emphysema. Yeah, you got it. All right, so you
It doesn't matter.
It doesn't matter. All right, it doesn't matter. And if you just think like that, now that I tricked your mind into thinking like that, you'll never get this wrong on a test. There's one exception to the rule. What is it? And again, not substance induced, not due to another medical condition. We know that. And again, I'm not trying to trick you.
Like with psychosis?
Each other.
More specific.
like if it alternates mania with psychosis, or at the same time,
Or
like
not.
schizoaffective.
Exactly right. Schizoaffective disorder of bipolar type is the only mental disorder that can be diagnosed other than bipolar 1 when there's an established manic episode, period. Right? So again, think that way on your exam. And when I say established manic episode, inherent in that, implicit is that the direct physiologic effects of a substance or medical condition have been investigated and ruled out. Hence, established episode. Right? All right, so do we think this is bipolar 1 or bipolar 2? Again, bipolar 2 would be hypomanic episodes, alternating with major depressive episodes. We think it's 1? Okay. What if this was a hypomanic episode? If. It's not. If it was, if it alternates with major depressive episodes, okay, again, SIGI caps, 2+ weeks, 5+ symptoms, clinically significant, we call that bipolar 2? Then what's cyclothymia?
For 2 years, right? And you don't have the hypomania.
You do.
But it's like, it cycles off for like 2 years with no less.
It could.
Would it break at like 2 months?
But what are we talking about cycling? What is it that's cycling?
The mania, the symptoms of hypomania.
Hypomania plus what?
Depression.
What?
The depression, like.
More specific. Minor depression. If it's major depression, it's bipolar 2. But if it's dysphoria that does not meet criteria for a major depressive episode, often referred to as minor depression, that's cyclothymia. Then you can add in all the rest, a pattern of 2 years, et cetera, et cetera. But it's important to first establish what it is we're talking about. Right? So both bipolar 2 and cyclothymic disorder have evidence of hypomanic episodes. In one case, those hypomanic episodes alternate with discrete episodes of major depression. In the other case, cyclothymia, they alternate with episodes of minor depression. So if you build a 2x2 rubric, and across the x-axis, mania, hypomania, y-axis, major depression, minor depression, you can easily fill in those 4 squares now with bipolar 1, that's across the top when there is evidence of mania. Bipolar 2, that square that links hypomania with major depressive disorder, and then cyclothymic disorder, that which links hypomanic episodes with periods or episodes of minor depression. Right, so again, something that might appear in exams.
Wait, which is the one that's hypomania with major depressive?
Bipolar 2.
And hypo with minor depression is cyclothymia, as long as it's 2 years.
2x2 rubric. Mania, hypomania, major depressive disorder, minor depression. Okay? I switched the axes on you.
Yeah.
If it's mania, it can only be bipolar 1, period. Right? So, very straightforward there. If it's hypomania alternating with periods of major depressive disorder, that's bipolar 2. Hypomania with alternating minor depressive episodes is cyclothymic disorder.
And does cyclothymic have to be to the 2-year mark?
Yes, it's got to, yeah. Because in terms of intensity, there's a lower threshold. What we make up or what we lose in quality, we have to overcompensate with quantity. That is, it's got to go. That pattern's got to be established over 2 years.
And is there a time frame where they can't be hypomania? Like they have like 2 months in between episodes or something like that?
I'd have to double check that. I'm not so sure that's going to come up on an exam though. I do want you to know that though. All right, so Goins presents to you. Biopsychosocially, what can you offer him?
Mood stabilizer.
Mood stabilizer. Okay, so choose one.
Lithium.
Lithium. So you want to start Goins on lithium. All right, so let's say you start him on lithium day 1, we'll say 300 milligrams. We'll start off at a low dose. I'm not so sure it's going to do the trick. But let's say you start them off with monotherapy, lithium 300 milligrams. What day are you going to get a lithium level? 5 half-lives. 24 hours is the half-life. Even I could do that math. It's 5 days. So lithium should reach steady state. Of course, if he's compliant, I'm not so sure this character will be. 5 days, check a lithium level. At 5 days, or even at baseline, are there any other labs you would like to check? Sensitive TSH. All right? You're monitoring for lithium-induced hypothyroidism. If a patient on lithium therapy, now stabilizing lithium therapy, it's working. Years on lithium therapy, TSH is found to be elevated. Next best step.
Give them T4. Give them T4.
Yeah, right? So T4 is the answer here. We actually treat the side effect, right? Rather than switch the medication, right? So T4 Synthroid is one of the few non-psychotropic medications that psychiatrists routinely prescribe. So that is the single best answer. Any other labs you want to get here?
Kidney function.
Kidney function. So BUN, creatinine, lithium-induced nephrotoxicity. Sure. Okay. Anything else?
When you do history, later down the line to see if he has like polydipsia, polyuria.
Yeah, so you're looking for lithium toxicity, right? So if he presents with acute onset, signs and symptoms of lithium toxicity, so mental status change, polyuria, polydipsia, unstable gait, tremor. So next best step?
Discontinue.
Well, dialysis.
Hemodialysis, exactly right. Hemodialysis is always the next best step, okay? It's not activated charcoal, which I guarantee you will be answer A, at worst answer B. Hemodialysis will be at best answer C, probably answer D. Read all potential answers, it's hemodialysis. Good, any other labs you want to get? We usually get a sodium as a marker of volume status, and we usually get a calcium for lithium-induced hypercalcemia. While all of these tests, including lithium levels, are done every 3 to 4 months, at least for the first year. The calcium is usually done annually.
What's the mechanism of that?
It's toxic to the parathyroid. There is some evidence in the literature, I don't think you'll be asked this, that it may actually unmask adenoma, parathyroid adenoma, resulting in the hypercalcemia. Right, so be careful, bipolar patient who presents with kidney stones, right? Presents with constipation. Think of all the acronym for hypercalcemia. On lithium therapy, check calcium. All right. Any other questions on lithium therapy? By the way, patient presents, what's the treatment of choice for lithium-induced nephrotoxicity, other than discontinuing the lithium? No, not acute renal failure. But let's just say this changes in specific gravity, which may be the earliest sign, on a patient that's been stabilized here. Diamox. Just be careful. Pick a Diamox.
What is that?
Acetazolamide. Right? Is it a thiazide?
No, acetylcholine.
No, I think it's a carbonic anhydrase inhibitor. Right?
Oh, it's the-
You're really testing me, dude. I graduated a while ago.
Okay, yeah, I remember that.
Yeah. All right. Any evidence that our patient is on? I mean, the fact that he's manic would suggest that he is not on lithium. However, let's say he was. And let's say he's compliant.
Check a lithium level.
Let's say his lithium level has went from therapeutic just 2 months ago to now subtherapeutic.
Check kidney function.
Just if kidney function is normal.
Is he taking it?
Is he? Yes, he's compliant. Yes.
Then switch his
Up the dose. Any other questions you want to ask our patient? Subtherapeutic lithium level in just 2 months ago, perfectly fine. The only physical finding is that you think he may have a sprained clavicle. Rates his pain 6 out of 10.
Is
Yes, he is. Right? So NSAIDs then, you've got to be careful. Actually, I take that back. It's the opposite. I take that back. The NSAIDs would be consistent with elevated lithium levels, right? In this case, we're thinking that they're subtherapeutic. So let's talk about what can raise the lithium level first before we get back to this case, where there's evidence of mania despite his taking his medication. So first, just a quick detour. Medications you can't take on lithium because they could increase levels of LEN2 toxicity.
Diazodiuretics.
Good, thiazide diuretics. Any others? NSAID, well, yeah. Calcium channel blockers and ACE inhibitors. Right? The acronym is actually CAN't. Right? Medications you can't take. Calcium channel blockers, ACE inhibitors, NSAIDs, thiazide diuretics. Now you could take them. You got to be very careful. Right? But if you say you can't take them, you'll remember the acronym. The opposite of can't is that, or you're exactly right. Or could. Right? Could is an acronym to remember the medications that can interact with lithium and lend to lowered lithium levels, and that might be the case here. So what are those medications you might inquire about here?
Carbonic anhydrous inhibitors.
Yes, so that's a possibility here. That would be the D, that's Diamox.
So basically anything that's gonna increase like renal clearance, right? Like-
Caffeine. Okay. Osmotic urinary agents. Osmotic, so that's OU. L, loop diuretics, Lasix, L. And then D is Diamox. Right. Now, I don't know if there's any evidence of anything. It would be great if he had some kind of acute pain syndrome, because actually, I keep on getting to the NSAIDs. It's not. It would be good if we see him drinking a lot of coffee. That would be a wonderful clinical finding, albeit unintended in this movie, to suggest why a patient who's being treated adequately and prescribed adequate doses of lithium may have a subtherapeutic lithium level and therefore be manifesting manic signs. Right. But I don't know if anybody here think that there's excessive use of coffee in this movie?
Probably not.
Yeah, probably not. By the way, is there another Brad Pitt movie where that is the case?
Oh my goodness.
Signs of mania, and the character is drinking coffee throughout the entire movie.
Fight Club?
Yeah,
Really?
yeah. Yeah. So it's the Brad Pitt universe.
Which one?
Fight Club. Now, the idea of coffee in Fight Club, sorry about the tangent, is not necessarily Brad Pitt's character drinking, but evidently, and this is on the dark movie web, there is evidence of coffee, specifically Starbucks, in every scene in Fight Club. That's an Easter egg. So sure, caffeine-induced lowered lithium levels in a lithium-treated narrative.
I don't remember that.
Check it out. We would never say it if it weren't true.
We didn't talk about that.
It's violent.
I'll let that little Easter egg slip through.
Rom-coms?
All right. Oh, what happened?
No, she's very picky with her movies that she likes.
Yeah, I thought I heard the R word. It's not to be mentioned in this room.
Rom-com?
There it goes. I would think Fight Club is a rom-com.
Arguably,
Yeah.
there could be a lot to say about people in rom-coms just as much as the movie. That's all I'm saying.
Got it. Noted. All right, so any other observations in our main character here? Goins. So we think this may actually be a case of bipolar mania. Any other characters you'd like to discuss?
I guess the psychiatrist.
Right. So what's going on? So what's the Cassandra complex? What's that
I
about?
looked it up.
Oh, then don't say it then. Anybody here know what it is? Before we give everybody a chance to guess. Now, anybody here into Greek mythology?
Yeah. That? Yep.
Yeah.
You got a yes out of me?
Cassandra complex?
I don't know what that is.
How about, was it the is it the house of, is it Arcturus or Atreus? I'm probably mispronouncing it. The house Agamemnon.
That sounds familiar. I
That
don't know why.
sounds familiar. Oh, it's that little thing called the Trojan War. His wife, Helen. No?
I know the story.
So, if you know the story, you'll tell me who Cassandra is.
The mistress.
You got it, right? So, Cassandra, other than being the mistress of Agamemnon, who he actually takes back with him from Troy, to meet his wife, Clytemnestra, I left that with work. By the way, he gets assassinated. Doesn't work. Previous to meeting Agamemnon, I believe it's the god Apollo who lays eyes upon Cassandra and basically asks her out the way Greek gods do. She rebuffs him. So, unfortunate to her, she's cursed. She's cursed with a gift of prophecy. That is, she can see what is imminently in front of her. Unfortunately, she is powerless to change the course of nature. That is, nobody will believe her. She sees the imminent death of Agamemnon. But despite the fact that she tells him and she tells everyone she could, nobody believes her. Agamemnon is assassinated by his wife and her lover upon return to his kingdom.
It's like Final Destination.
It's just like Final Destination. Right? It's also like 12 Monkeys.
Yeah.
Cassandra complex. Okay. Don't know if it really has a parallel to psychiatry. We could have people present telling us they could tell us the future. I think choice B, psychosis dissociative, might be an initial thought that a clinician may have when a patient presents with a delusion, perhaps a grandiose delusion, that they can foretell the future. If it's the Cassandra complex, maybe it's a persecutory delusion, that it's more than a curse than a gift. All right, so that's the Cassandra complex. That starts the idea of what might be ailing our psychiatrist. Now here, even though shared psychotic disorder is a condition I do not like to talk about too often, because almost every movie, whether we call it a thriller, psychological thriller, whether we call it horror, likely manifests shared psychosis, right? Somebody who believes in something, nobody believes them, and at the end of the movie, everybody believes them, but it's too late. Right? That's the narrative, that's the story arc of every movie we watch, which means that every movie we watch is about shared psychotic disorder. But this is no different. The interesting twist here, which is why we will mention it today, is that we're dealing with a psychiatrist. So there is evidence to suggest that someone she has seen, someone she has treated, may have been psychotic. That's really not out of the ordinary. And we may get an idea of this long-standing relationship, not father to son, not mother to daughter, not husband to wife, but doctor to patient, that could have been the impetus to her developing this delusion. And of course, we see our patient, right? And that's the character depicted, that's Cole, portrayed by Bruce Willis. Right? So, not a bad depiction of shared psychosis. How do we cure Dr. Is it Riley? Rayleigh. How do we cure Dr. Rayleigh if she presented to us as a colleague? I need help. I have this belief that I can foretell the future, but do nothing about it. By the way, it's just like that character back in Greek antiquity named Cassandra. Help me. What are we going to ask her? Or what are we going to put in our biopsychosocial treatment plan?
CBT.
Potentially CBT. What else?
Antipsychotic.
Maybe antipsychotic is necessary, but even before the antipsychotic, what else? We are going to ask her to transfer her patient to another physician. We are going to stop that relationship, because if this is truly shared psychotic disorder, once she no longer sees Cole, her psychosis will resolve. Unlike relationships that are within a family, her discharging the care of her patient to another psychiatrist will, I think, definitively cure her. It's not the same when it's father to son, because usually after the hospitalization, the son returns, and to the extent that the delusions may recur, so too will shared psychotic disorder in that family unit. Not the case here, so this might be curative. I have to watch the sequel. There's no sequel, by Anything else for really? So I think delusional disorder, and we'd have to struggle a little bit, grandiose versus persecutory type, depending on whether this is a gift versus a curse. By the way, really interesting, another movie about, again, a modern adaptation, modern equals 80s, adaptation of the same Greek tragedy with the same tagline, curse versus gift, angel versus demon, depends on your perspective. By the way, anybody gets this, undergraduate, medical, instant honors.
Give me a hint.
I just
An
did.
80s movie?
80s film.
That's not modern.
80s film that also deals with the same exact Greek tragedy as the 12 Onions.
Terminator?
Not the Terminator, with the same idea, if not exact, dichotomy. Angels to some, demons to others. Google angels to some, demons to others.
Is it the name of it?
By the way, it's no longer for honors.
Hellraiser?
Got it. Right? Hellraiser. Hellraiser is a remake of that same Greek tragedy. I know you didn't see it. That's why you're going to put it on your short list now. That has that same dichotomy. Its perspective. Is it a gift or is it a curse? Angels to some, demons to others is the tagline of that movie. So I'm watching those movies back to back. Another one. I wouldn't make it in my top 10 though. Any other characters you want to discuss? To close out, what are the other themes or what are the other subtypes of delusional disorder other than grandiose and persecutory? Erotomatic, good.
The Capgras one.
The Capgras one is a undifferentiated or other category. That's good. I want to get to that in a second. So the acronym is JPEGs, right? Jealous, persecutory, erotomatic, grandiose, and somatic. If your patient's delusion does not fit into one of those categories, undifferentiated, Capgras or Capra would be an example of that. The delusional belief that a person, usually close to you, can assume the guise of others. So it's the shape-shifting syndrome. There's another where you have the delusional belief that you or part of you is dead or dying. What's that called? That comes up on shelf exams.
Necromancy.
That is the Qatar Syndrome. Right, that's the Qatar Syndrome. By the way, a movie about a character afflicted with the Qatar Syndrome, the delusional belief that he's dead, is The Sixth Sense. Starring? And we'll end it there, right? Another Bruce Willis film, The Sixth Sense, Qatar Syndrome, that is a form of delusional disorder as well. Right? We do have evidence that 12 Monkeys links directly to The Sixth Sense. The character Cole is actually in both of these movies, but I don't want to get too far into that. First of all, it's a Friday. Second of all, it will not come up in your shelf exam. So to be discussed at another time. All right, we'll end it there. Any final questions? All right, thank you, everybody. And we'll sign off.